You're welcome. So for 24 of December, I think we are there. Another examination, midterm examination is upcoming examination is we will have, I think, and this examination will refer to the disease, the periodontal diseases, the tumors, then some fractures also will be included, incorporated in that part of midterm exams. So my request will be from your side to make a major focus on tumors, cysts, a little bit about fractures. So we will restrict it on the in cases of fractures that occurs, and that occurs especially in the dental region, or the injuries of the tooth itself, not in the broad injuries, as for example maxillofacial region, because we will deal with that in this surgery and maxillofacial surgery. So this will be better for us to make more hello, Adam. More focusing on the first part of the fractures, okay? And a little bit the mandibular fractures and so forth, mandibular fractures and the fractures and the mid face of the maxillofacial region. So, and for today, also we will talk about a little bit, I might have a little review about our last or left part from this section, from the fractures, from traumas, and especially we will have to talk about the infectious control. That is very, very prominent for today. Infection control, especially because of the reason of our online lectures. This is a well-known infection, as you know, the SARS-CoV-19, so forth, and hopefully this kind of infection, hopefully, I have a very, very good intentions from the vaccines, but so far no results, but there is a great a big good intentions and big and great huge hopes from the vaccinations that as I think in some countries has already began, I think in the United States. So, but for the vaccines to be manufactured, for example, very little period of time, only 18 months, only 8 months or 9 months was passed from the burst of the pandemic. Hi, Miriam, and this very little period of time is not so sufficient for manufacturing very effective types of vaccines. But we are looking forward, we are looking very eagerly and hopeful for the future to have good results, having a good results with vaccination, because this prolonged distance, distancing the people from each other gets very, very bothering, very bothering. So, okay. Let's begin to talk about a little bit about traumatic injuries of the facial bones. And as you know, we had talked about the fractures of the alveolar process of the region of the dental region, especially. So we have dealt about the fractures, of the tooth, the coronal part, the root fractures. So the fractures, the alveolar process itself, and so forth and so forth. And now we will talk about a little bit about the fractures of the facial bone, especially the mandible. Hi, Sarah. How are you doing, Sarah? So now I will try to make the now this is an infection control. So now I will show you the Gosh. So again, Sanjay and Malia, you know, our favorite textbook. So now here, this is a panoramic X-ray showing us the gross anatomy of both jaw bones, two-dimensional X-ray imaging that is very helpful to identify the mandibular fractures, especially in this region and the ramal, the body region, and so forth. And the mandible, and mandibular fractures. This is the most commonly occurring fractures, as you know, that we encounter during our clinical practice because of falls, for example, because of assault sometimes after fighting, especially with boys, of teenagers, and also because of the motor vehicle accidents. That is very, very common and not so infrequent. So this bone is most common, is most frequently injured and fractured after these kind of accidents. And the age range of mandibular fractures just renders within 18 years and 54 years approximately. That is stated here. So, as it's stated here. So the mandible and the diagnosis in radiology plays a very crucial role to identify the exact site of a fracture. So it facilitates us to make a diagnosis and also to manage with this kind of fractures that are so multiply represented in during mandibular injuries, that there are the special classification, even more, there are special classification of the mandibular fractures on the basis of location of the fractured lines and on the basis of orientation of the plane of the fracture of the injury. So the X-ray imaging is very crucial and very helpful in diagnosing these. Sometimes the lacerations and the injury of the soft tissues covering the fracture sites makes us available to focus on the existing fractures. So afterwards, if the patient is cooperative, for example, for extraoral imaging and sometimes for intraoral imaging, as for example the periapical imaging, also may be helpful for identifying the fracture line that appear, as you know, as a radiolucent lines on the X-ray imaging. And especially for the mandibular fractures, we use the panoramic X-ray imaging that is represented and that is displayed here. So the favorable sites for mandibular fractures are the symphysis area, the parasymphysis area, the body of the mandible, the angular part of the mandible, of course, and the ramus, the condylar region, especially the fracture of the condylar head. This is a condylar process, yes, one of the process of the mandible, and especially the fractures of the condylar neck. That is very popular from indirect fractures of the mandible, and the fracture of the coronary process that is not so frequent because of its position. So when we are talking about the mandibular fractures, as we have mentioned, that is very, very special for us to identify or to pay an attention towards the unique anatomy and morphology of the mandible. So we begin with the classification when we are talking or when we're speaking about the type of fractures of the mandible. We have to mention about the location of the fractured line and also the direction of the force of the impact of the injury. So depending on the location, for example, the classification is as follows. The fracture of the symphysis, as we have mentioned, the location of the fractured line in mandibular body, the angle, so the ramus condylar head and condylar head fracture, and neck and coronoid process. And what about the pattern of the mandibular fractures? The other classification or clinical classification also exists. For example, we define the fractures as to be, for example, single fractures of the mandible. This means that with the single fractures, for example, or the simple fractures of the mandible, there is no communication with exterior. So the parts of the bony fragments or the bony fragments that are embedded within the soft tissues, they have no exterior connection, without no communication of with the external environment. In contrast, they are the compound fractures. The compound fractures, in contrast with the simple fractures, they do have the communication with outside, with lacerations of the oral mucosa, for example, or via the damaged periodontal ligament space, or, for example, from the damaged facial skin, and so forth. Also, we have to mention about the comminuted fractures. For example, sometimes we identify the multiple bony structures at the fractured site. When the multiple bony fragments are represented due to the highest force impact, sometimes that accompanies this kind of, that results in this kind of fractures, that are comminuted fractures, we identify not the solitary line of the fracture, as for example shown here on the panoramic X-ray radiogram. You can see that is displayed very nicely here. So the comminuted fractures, also we may have the so-called green stick fractures. Green stick fractures involve only one plate of the mandibular cortical layer. For example, it may be the buccal or only lingual layer, as usually indoors. Typically, these are the buccal part of the mandible. And in green stick fractures, the shape of the jawbone is changed as a result, but the bony fragments are not displayed from one another. Okay, then comes also we have to mention a little bit about the kind of fractures that are the complex one, because they involve adjacent vital anatomic structures. Sometimes the fracture of the jawbone, of the lower jawbone especially, may cause the rupturing of the adjacent nerves and vascular bundles. For example, the fracture of the mandibular body part, for example, in this area, may cause the rupture and the damage of the intra-alveolar neurovascular bundle. So this we call them, and it is represented as complex fractures. And by the way, we have to mention about the indirect type of fractures that we also most commonly observe with mandibular traumas, because, as we have mentioned earlier, the unique morphology of the lower jawbone, we are just focusing only on the mandible, not the maxilla. So because of the unique morphology of the lower jawbone, what does it mean, the unique morphology? It means that the thickness and the width, the buccal-lingual thick, okay? So I will show it, or this is very nicely represented here. You see that the bone is carved.
Sorry, Professor. Okay? I don't think you're displaying the screen, the image that we can see. Well, I can't see it.
Oh, you can't see it, so I will magnify it. Okay, Maria?
Okay.
That's right. That's good, Maria.
Oh no, I don't think you're displaying the right screen. All I can see is you.
Yeah, yes, that is the screen that we are talking about from our topic.
No, doctor, we can't see you don't share a screen.
Oh, sorry. I'm sorry again. It's my fault. Sorry. Again and again, I will try
No problem.
it once more. Okay, thank you for your. I'm sorry. I had forgotten again because of my. Oh my God. I'm talking about sharing and not sharing the screen. Beautiful. So now I will begin sharing with this. Okay. Now?
Thank you. I can see it.
Yes, it's good. So, okay. Thank you for your mentioning me about this, Maria. So, we were talking about the fractures on the lower jawbone and especially the role of the panoramic X-ray displaying those parts, those fractured lines. Sorry, I have. Oh, here. You see? So this is the panoramic X-ray that shows beautifully the anatomy, the gross anatomy of the upper and the lower jawbone, and especially for now we are dealing with the mandible. So we have told about the kind of the pattern of the mandibular fractures and the specificity of the mandibular fractures that is defined by the direction of the force of impact, the danger of the injury. So here we see the fractured line. Okay, here we see the fractured line, and now this is a solitary fracture, and I hope this is not the compound type of fracture that has the communication with external environment. So now we are dealing with the indirect pattern of fractures or indirect fractures. That is very, very common with mandibular injuries after direct impact that is directed on the mandible, especially in its anterior side. So why? Because of its unique anatomy and unique morphology, that the mandible is curved, as you know, and the width of the mandible is different and it's different areas. So the regional anatomy, there is a regional differentiation with the buccolingual width of the jawbone. And because of that reason, when the force is directed to the especially anterior region, for example, to this, because of fist, for example, when the direct force is applied on the anterior region of the jawbone, the force is transmitted through the bony tissue to the distal areas, that is truly very distant from the site of impact, and that may cause the fracturing of the distal anatomic parts of the mandible. For example, such a case as applying the injuring force on the anterior region of the mandible may cause the fracturing of the condylar head. You see here, for example, here, and this kind of distal or distantly occurring fracture rising distantly from the site of injury, for example, very commonly occur because we call this type of fractures as indirect fractures. You see, with combination of other types of fractures, we may receive the unilateral or one-sided or two-sided bilateral fractures of the condylar neck in that area. So we have talked about we have dealt now towards this kind of fracture, the indirect fracture. But by the way, we have to mention about the green stick fractures. The green stick fractures that we have told before, for example, here we have the singular fracture. or the simple fracture, but the green stick fracture means that when the only one part of the cortical area is damaged, and the shape as a step-like appearance appears, for example, this occlusal X-ray imaging. So we may identify the discontinuity of one part of the cortical area of the jawbone, but the other part is continuous without any kind of damage. So the shape is changed, but the parts of the jawbone are the bony fragments are never displaced from one another. So we have also have talked a little bit about the pathologic fractures, and especially we have dealt with the pathologic fractures from our previous topics, as with patients having cysts, or with patients having benign neoplasms, or even with patients after treatment of malignancy, after radiation therapy, for example. So these are the pathologic kind of fractures of the mandible. The pathologic fractures arises in absolutely absolutely normal, sometimes normal physical forces, or because of very, very minimal traumatic forces. They may arise anyway and causes resulting in fractures of that area because the pathologic process that is increasing, and sometimes the patients are unaware about having this kind of pathology. Besides the cavities, intra-bony cavities are increasing, and the pathologic cavities compromises the integrity, the morphologic integrity of the jawbone, and because of that, we receive the pathologic fractures of the lower jawbone. So here are some specificities, some specific features that we may encounter during X-ray imaging. We have mentioned already, the X-ray imaging is very crucial for identifying the orientation of the plane of the fracture. Of course, here, for example, at the angular region, and you can really identify the unerupted tooth, or sometimes retained 8 tooth in the mandibular angular region, for example, as shown here on this radiogram. And this kind of positioning of the retained tooth, or anywhere the fracture line goes through the total structure of the mandible, where the tooth exists, treated or non-treated, this doesn't matter. You see, we have to extract the tooth to mobilize the fractured bony parts, or the fragments. So that helps us to make the fixation with the when we are making the intermaxillary fixation. So this in this case, anyway, we have to extract these tooth that is positioned, or that lies on the line of the fracture, because of the risk, because of the high risk of infection, and inability to make the mobilization of the bony particles. So you see here, these tooth inevitably will be extracted from this site. So afterwards, for example, this is very interesting. This is a CT for the fracture site. Again, the angular area. This is a very common site for the mandibular fractures, and you can identify the sagittal view of this region, of the mandibular region. You see the radiolucent area that indicates towards the existence of the fracture line. Then this line is prolonged towards the non-erupted tooth. Okay, so it is prolonged again and again, and ultimately it shows that it reaches the total width and traverses the total width of the jawbone here. So again, here's a very interesting presentation for the identifying the orientation of fractured lines. Here, for example, this is also a presentation for a kind of X-ray imaging that we sometimes make, especially in the maxillofacial, especially and when we're dealing with surgery, for example, this is a lateral oblique image of the lower jawbone. Lower jawbone that shows here the image, and we will have an impression of having two fractured lines here. One and the second that converge with each other just a little bit above than the inferior region, inferior border of the lower jaw bone. But the occlusal imaging of the same mandible shows very different X-ray imaging. Yes, and you can conclude that here in the premolar area we have one solitary fractured line, so that goes through the total anterior body part of the mandible. So here we can conclude that there is only one fractured site, not two of them that we can conclude from the first image, but only one singular fractured line here. So again, and what about the management of the mandibular fractures that we will deal with when we will deal with the surgery, the treatment of the fractures and so forth. And we have for today, after diagnosing that the teeth are aligned just very closer, or just they are in line of the fracture of the mandible. And when we diagnose on the X-ray imaging that the teeth are very close to that part, the inevitable extraction of these tooth must be conducted for the future, must be planned for those parts of the mandible to be mobilized just in closed or in open mobilization that we conduct after fracture, during treatment of the mandibular fractures. So then comes another very, very common part for the mandibular fractures are just the condylar that we are dealing with, the condylar process, the fractures of the condylar process of the mandible. So we have two processes, as you know from anatomy, the condylar process and the coronal process. So the most commonly occurring fractures we have in the condylar head especially, and the condylar neck part. So these frontal scanning, the computer tomography shows that very area that is very common for this site of the fracture, and you have to pay attention of the direction of condylar head itself after the fracture of that site. That the condylar head is directed a little bit inferiorly, anteriorly, and medially. If you are so pleased, which one of you may explain me, for example, and very briefly, why is the specific orientation, for example, for the condylar neck will be followed or accompanies after fracture of that side? How do you think why this part, the condylar neck and the head especially, is directed medially and not, for example, laterally after fracture of that region? Because of the insertion at these sides, the lateral pterygoid muscle. Okay, the lateral pterygoid muscle that helps the lower jawbone in opening and especially in protruding, just making this motion. You see, protruding anteriorly when opening the lower jawbone. And a very specific feature for this kind of fracture, or for the fractures occurring at the neck of the mandibular condyle process, is the inability of the patients not only to open, it's very hard for the patients with this kind of fracture to open the mouth sharply, but also to protrude anteriorly the mouth, okay? Because the heads of the condyles are fractured and displaced medially, as shown, for example, ideally on this figure. So, okay, so the head is displaced medially, and now on this figure, you have identify, and this figure displays the further complication from this kind of fracture. What is this? The osseous ankylosis. So if you focus on this area very attentively, you may identify the elevated radiopacity within these two parts. This is a residual part of the condylar neck of the lower jawbone and the temporal bone. And if left untreated, we may observe this kind of post-changing occurring after fracture of the condylar neck area. The head is directed or displaced medially because of contracting forces of the lateral pterygoid muscle that is attached to the neck, to that side, neck sides of the mandible, and afterwards, if left untreated, for example, this area, the osseous ankylosis may occur. So to avoid this kind of complications that will follow sometimes, maybe some, but in most cases, this area must be, or the fracture site must be mobilized. And afterwards it has to be treated in the right way. Okay, sometimes it needs the open surgery, but in most cases, because the open surgery of that area leads for more complications, it is better to treat it in an enclosed manner, so with fixation or intermaxillary fixation and immobilization of the lower jawbone. So these are the examples, very fine examples for the lower jawbone fractures that we occur most commonly during our clinical practice. And you see the meaning of the X-ray imaging, and the thing that we have to mention here, that if for example, the panoramic X-ray imaging is very helpful and informative by means of identifying the fractured lines, in the mandibular body or angle or rameal area. When, for example, the condylar neck area fractures, especially when the fragments of the area is not displaced, it is almost always impossible to identify the fractured line or diagnose the truly existing fracture of that area, of this area, under panoramic imaging. So when we suspect having the condylar neck fracture, we have to make the multi-detector computed scanning or CBCT scanning anyway to identify those lines, because in panoramic X-ray imaging, for example, shown on this diagram, this is in most cases, and especially when the fragments of the bony fragments are not displaced, it's hard to identify. It's very hard to identify on the panoramic X-ray imaging the type, direction, orientation of the fracture plane after condylar neck fracture. So if condylar neck fracture is suspected, we make multi-detector computed scanning. It's better. You see, it's better in three-dimensional space, viewing the line, the direction, and displacement of the condylar head, okay? Because it is displaced medially, and it's hard on the kind of two-dimensional panoramic imaging to identify them. But if other kind of fractures in symphysis, for example, in bone and other parts of the mandible that is very, very nicely visible, we use the panoramic X-ray imaging. And if the patient is cooperative, of course, we may conduct the periapical X-ray imaging, but better is the panoramic X-ray imaging. And also, the very special thing that we have to pay an attention during estimating the fracture lines on the panoramic X-ray imaging is the fact of superimposition effect of anatomic structures of the oral cavity or covering mucosal layers and so forth, and the mandibular bone, because sometimes the there are, for example, air distally positioned air spaces and the pharyngeal region. They sometimes superimpose, for example, as shown on this diagram. Yes, you see, superimpose on the expression of the lower jaw bone structure, and we mistakenly may acquire it to be the fractured lines. But no, the characteristic feature for the fractured line is that it is confined within the anatomic structure itself. For example, as shown here in this diagram, you see, it is confined only when these solitary anatomic structures, not prolonged throughout the total X-ray imaging. So here, for example, it is confined only with only one anatomic structures, not prolonged. Not prolonged, as for example, here on this X-ray imaging, there are several and multiple X-ray imaging that may show or express the additional lines corresponding with the superimposition effect, but remember that those superimposition effect of the other anatomic structures, for example, they correspond to the really existing anatomic structures. For example, here you see the inferior alveolar canal. So this is not the fracture site, of course. It is prolonged, and it keeps going towards the site that it leaves the lower jaw bone structure. So we have not misinterpret those kind of anatomic superimposition effect with fractures. But sometimes this kind of events occur, unfortunately, and the fractures are misdiagnosed. Sometimes it occurs. So, and because of this kind of suspicion, if such kind of suspicion will be raised, we have to make the multi-detector computing scanning that is simple, and the existence of the fracture, really, the truly fracture, will be diagnosed or not. So what about the mid-fascial fractures? Mid-fascial fractures, especially orbital wall blowout fractures, for example, are also very, very popular with very heavy complications. You see the fluid and air space, the maxillary space is very restricted at the fracture site, for example, and because of the direct force that is directed to this area, for example, the orbital area, especially from the very large, and this is the fist, for example, that cannot enter the orbital cavity. It causes the fracture of this area, of the floor of the orbits, and the soft tissues sometimes are entrapped within the maxillary sinus, and it's a heavy clinical picture for the edema, increases in size, and endophthalmosis, and the patient cannot can have the diplopia. So making the multi-detector computing scanning is mostly informative in this kind of situation, and especially not only informative, but also this is an particularly typically we make only one choice for making an estimation this kind of situation, just making and performing the multi-detector computing scanning to finding the just exact site for the occurring fracture. So here also the fractures of the zygomatic bones, that is also not very seldomly occurring fractures in the mid-facial region, and the fractures of the maxilla is not so oftenly occurring. The most common that we have deal with is then mandibular fractures, and the utilization of multi-detector computing scanning is very, very helpful for identifying those kind of fractures. See here, because in most cases, for example, the patients are uncooperative with these fractures, and you see here the fractured zygomatic process area, for example. So sometimes it's very hard clinically by symptoms only to judge with the fractures, with the really fractured sites. It's zygomatic bony fractures or other parts of the facial bone. So the multi-detector computing scanning helps us to identify them. So no other plain imaging, such as, for example, the two-dimensional imaging, or, for example, as panoramic X-ray imaging, is useful for identifying those parts of the. We always make choice on the multi-detector computing scanning, okay, when we are dealing with the fractures of the mid-facial part of the maxillofacial region. So also the MRI, because of an involvement, the extension of soft tissue involvement to identify the extension of soft tissue involvement is also very helpful. So please wait a minute, because it's charging my computer. So I help with this. So I think everything now is okay. So that's where the things that we wanted to make a little review about fractures. Now you understand the major radiography that we conduct for the patients with fractures of maxillofacial region are the multi-detector computing scanning, MRIs, and the mandibular. With mandibular jaw bones, we utilize the occlusal X-ray imaging and the panoramic X-ray imaging. So afterwards comes the more broadened types of fractures, the Lafort one and second and the third. These are very hard, very huge kinds of fractures that we will deal as very high, very huge information. So we will have to focus only for that up to Lafort fractures, okay? Just focusing on those parts, not the Lafort fractures. The Lafort fractures may be only for reading, okay? This will be better for us because upcoming midterm exams, this will be very huge information for you for memorizing. So these are the major topics that we wanted to consider for today. And afterwards, now then, we want to speak about the major topic of our discussion, especially for today. This is an infection control that is that got very high interest, especially in our field in dentistry. This is the infection control, as you know, was always prominent in our profession. You know, we the dentists were the first doctor, the only doctors, I think, the only doctors that are very close to the oral cavity. You see, we are the doctors that are very close towards such kind of diseases, especially infectious diseases that have spread by blood, by air drops, and so forth, and are also very contagious. You see, these are hepatitis, for example, immunodeficiency syndrome, so herpes virus infections, and tuberculosis, for example, that are very threatening types of infections. But additionally, this kind of situation and the spread of the infection like the COVID-19 face us more faced as more complicated situation in terms of infection control, because the additional equipment was added for us to make the distance from our patient. But as you know, our discipline or the dentistry is based upon the practical skills, and is based especially on the performing those practical skills. We cannot work distantly from the patients. For example, my friend, he's a neurologist, and he is fond of the telemedicine, for example, that is getting very popular in the United States, and he is very successful neurologist, psychoneurologist in the United States, and he has his practice. He transmitted the total his practice in telemedicine, and he conducts his consultations approximately, as he estimated, is to be 30 states in the United States. He's very famous neurologist, so he works distantly and feels himself very comfortable in that kind of situation. Now, for example, he is in Georgia. He came to Georgia for helping us with managing the heart situation, and he is managing with very heavy patient with the neurologic complications. For example, the patients that are very hard to manage. Additionally, with the COVID infection, and he works distantly from his house. But imagine us as a doctors have been working in dentistry. How hard it is for us to manage with our patients distantly. Can you imagine yourself working and having a good results, or just talking with your patient only, explaining the situation, because the patients cannot do anything independently without our help. So we are the first doctors, unfortunately, to be presented just before oral cavity. That's the major part, unfortunately, is the major part from which these COVID-19 viruses are spread throughout. So we are suspected individuals. And we were suspected individuals as subjected to the spread of infections, not only as the COVID-19, also other very dangerous diseases such as AIDS, for example, such as herpes virus and tuberculosis and hepatitis. So this unique and universal infection control mechanism, for example, showing this is a very great figure showing that, but this figure is made, I think, before the burst of the infection of the COVID-19. But anyway, it is actual just nowadays. Because we always as a dentist, we always were following all of the recommendations that were faced before us, all of those recommendations that are issued by the American Dental Association, for example, or the CDC, the Center of the Disease Control. So anyway, these kind of universal recommendations and infection control recommendations must be followed by every staff member, by every individual working in dentistry. You see, to avoid, there is a kind of there's a kind of fact of cross infection. So what is the cross infection? How do you think, for example, how can you explain to me what will be the cross infection? What it would be, for example, the cross infection. How can we imagine what it should be, the cross infection? We know the direct infection and afterwards the cross infection. That is very, very important for us to know what the mechanism of the cross-infection, what it really is, what does it represent, the cross-infection. How do you think?
Is it using like the same gloves from one patient to another?
Yes, of course. Yes, of course. Maria, it's you or Cookie. I'm sorry, I cannot see here. Very sorry, but anyway, thank you. So again, what else? What else should be the ways by which this cross-infection may occur?
Using the same needle?
Yes, of course, the same needle. You're right, you see. Using the same needle, sometimes, you know, the years before, we, not me, but my one of my staff member was working at a very distant part of the Tbilisi center, the city center, and unfortunately, she observed the thing very, unfortunately, very, she was very worried about that. One person, one doctor was using one syringe. Can you imagine? For 3 patients. This is awful thing. This is, yes, using same mask. It is, yes, of course, using the same mask. You'll see that you're right. Thank you for your answer. But there was a fact. There was really a fact when the doctors utilized one syringe for every upcoming patient. You see, and because of that, in years before, in Georgia was a very hard situation in the field of spread of the hepatitis C and hepatitis B, because every 6th person in Georgia had got the hepatitis, and one of the major way of transmission, unfortunately, was recorded to be dentistry. You see, was recorded to be dentistry, but afterwards, dentistry in Georgia seems to be, because I think not only the economists, but this is this. I think that is a criminal. Yes, it's a criminal, but because when you use and utilize the one syringe for several doctors, or even more, you know, the carpools. Okay, this is the container for anesthetics, you see, and I will show you. Sometimes we use those carpools for only one patient. Okay, we are not allowed to utilize the carpool even when it is filled. Okay, even it is filled and halfly utilized, we should not utilize the same carpool for another patient. But in some occasions, there was recorded that sometimes some doctors utilize one carpool for several patients. Okay, this is also a very, very big mistake. This never had to happen in dentistry. So this is a huge venue and opportunity for infectious spread. So because of that, we call it the universal control mechanism, the universal infection control recommendations. Universal, why? Because there is no other alternative. You have to follow those recommendations. You have to follow, because you are unsafe. If you make something mistakenly, for example, and if you never pay an attention to the things that are going on in your clinic or in neighborhoods, the clinics, for example, anyway, you are in a great danger, because of opportunity, the huge opportunity for infectious spread, you see, and you are never defended from the kind of situation that you will not be the next person acquiring these deadly kind of infections. Inevitably, because if COVID-19 is treatable, for example, the AIDS is very, very hard to treat. Even more advanced researches are done in the field of treatment of AIDS. Anyway, it's costs too much for the patients, for example, the treatment of AIDS, this kind of immunodeficiency syndrome, and ultimately the patient dies because of not only from this infection maybe, but from the cancers that may occur, and in most of those cases, those kind of patients die because of cancers that are characteristics from the immunodeficiency, this kind of immunodeficiency syndrome. So anyway, we just mentioned that and talked and about that. These universal recommendations must be followed by every person, every staff member, to avoid this cross-contamination to occur. The cross-contamination from doctor to patient, from patient to patient, and so forth. And not only during our performing our endodontic treatment or surgery or any manipulation in the clinic, for example, but also in dental operatory room. It must be kept in mind always to follow those recommendations. So if my friend and my staff member is ready to help us, a little bit later we will show you the presentation, how do we manage with this kind of following this kind of recommendations. So anyway, since and after the AIDS were recognized, as you know, this event take place in 1980s, when this kind of virus that was called as acquired immunodeficiency syndrome was recognized. The infection control mechanisms and manipulations in the field of infections controls were prioritized. And especially now, 40 or maybe several years later, when we face this kind of infection as the COVID-19, the infection control procedures are more prominent, became more prominent, most prominent. So there also we have mentioned the other infections, viral infections especially, and bacterial infections also, as tuberculosis, for example, the herpes virus infections that is very, very common. We occur also the hepatitis, especially B, C, or just nevertheless what they are. So anyway, and additionally the COVID-19 nowadays became very, very actual and very prominent. So we have to avoid and we have to defend our patients from exposure to blood or airborne particle spread diseases, or from cross-contamination of this kind of infectious disease. Why? Because these precautions we have to follow anyway. That is recommended by EDA and CDC, the Center of Disease Control and Prevention. Why? Because you know, there are kind of we encounter during our clinical practice a kind of fact that sometimes the patients never record about their illness, you know. And we in Georgia also had many facts of that, especially, for example, me, because there were the patients and multiple patients, not so few of them, that came, and they never wanted to to tell about their disease or having them. And during peeking the history of the patients, we realized, and when we suspected something, because it is not so hard to clinically to identify those changes that is specific for for example, hepatitis C. Truly said, I never had recorded patients of AIDS, for example, but I had multiple patients with hepatitis B, for example, or in chronic phase of course, not acute, but there was also the acute hepatitis B patients, unfortunately. And especially the hepatitis C was very popular. And those patients, when coming and performing the treatment, the dental treatment, especially surgery, they didn't want to declare about the infections they had. Besides, they knew about that. Why? For example, some of those patients were claiming about stigma, about existence of the stigma. You know what does it mean, the stigma and stigmatization that they claimed about when they at their appointments or with their dentist, the dentist refused, just imagine, refused to treat those patients having hepatitis C. And poor patients, never could explain what was the reason of refusal for the treatment. You know, it's very hard when from the patient side to hear such kind of claims, but this kind of facts sometimes really takes place. And you know what? You as a skilled doctors, you never have to be refused the patients with this kind of infections. Why? Because those patients that are stigmatized, for example, in the field of infection, I am now focusing on the hepatitis, for example, hepatitis C, they always will hide their condition from the patients, and it's dangerous. They never will record about that because of the fear that they will be refused, and and the dentist will refuse in treatment of the teeth or extract the teeth and so forth. And afterwards, we carefully explain to the patients that anyway, they record or not about the existence of the infection. Sometimes the patients are never aware of having the infection at the when they're coming at their appointments. Nevertheless, we always, because of the recommendations, this unique of the infection control, we always follow and always perform step by step, always perform all the precautions that are recommended by American Dental Association and CDCs. And this is a great rule from the dentist, for the dentist, to be followed throughout the total career in dentistry, because to avoid themselves, the staff members, also the patients especially, and themselves from the spread of infections. And additionally, of course, you're coming the COVID-19. But nevertheless, the more dangerous diseases that are caused by other bloody spread infections, the AIDS, the hepatitis, they are more dangerous, just believe me, are more dangerous, more highly lethal outcome, and this depends upon us. So it depends upon us, depends upon our practice to avoid those patients or ourselves from the spread of infection. And especially, you know what, especially the placement, for example, the sensor, as I am showing now here you, for example, this is a sensor that we utilize for periapical imaging, the number 2 sensor. The placement of them, the intraorally, the receptor, also the handling of the tube head. You see here the tube head, okay? Tube head, and handling of the control panel. Can you see all the things that I'm performing now? I will try to make a big impression of myself. So can you see? This is the tube head. So I'm moving in. And also the handling the control panel, also the monitor. This creates the all kind of movement from the operatory side, creates so much ways for cross-contamination to occur that we anyway have to make much of our efforts to follow those infection control recommendations to avoid this kind of infection spread to occur. So there I have to show you the special solutions. So the disinfectants that are used for cleaning the surfaces. Okay, the surfaces of the sensor, the chew pad, the monitor, just before and after performing the X-ray imaging of the patients. And now I have to retell some steps of performing of X-ray imaging and utilizing the following steps of recommendations that we fulfill during our X-ray imaging. So there are multiple and several types of surface disinfectants that are very, very effective. So they're very, very effective by means of infection control. And also we use the clean water, the sterilized gauze or the sponges. So to remove the disinfectants build up all the sensors and all other surfaces. And by the way, we have to mention that there are some items of handpieces that we utilize that are subjected for heat sterilization. But in most cases, we are not allowed to heat sterilize these items. Okay, those are not heat sterilized, and because of that, we use the disinfectant solutions manufactured by different manufacturers. We use the best ones, the best ones for disinfection. For, of course, the coming patients to be used. So anyway, when we finally finish the X-ray imaging, the operator finishes the X-ray imaging, the operator removes all the coverings, the plastic covering, for example, or isolating materials that was used for the previous patient. But it is performed with gloves, of course. The operator always wears the gloves. So now I will try to show you that. I will try to show you that. So here the disinfectant, for example, that we always have to use. Sorry about this item. You see here the disinfectant, okay? This works perfectly, just believe me. So after performing the X-ray imaging on the previous patient, we remove the plastic covering. For example, I have just made the X-ray imaging, performed the X-ray imaging, and afterwards, the X-ray imaging must be conducted with the receptor covered with anything that is used for isolation. Yes, and afterwards, the operator removes this plastic covering, drops it out, and she places the contaminated receptor on the tray. That is his sterilized, for example, or any other towel that is disposable. So after placing on the tray that is, he sterilized, the surface is contaminated already, the operator removes the gloves, and afterwards she washes his hands, and only after that she gloves up her hands. With new gloves, okay? And after taking on the new gloves, she begins the disinfection. And the disinfection begins with cleaning the contaminated receptor surface. For example, we can that if there is a contamination with blood or other body fluids, especially from saliva, and the saliva and blood is for the first removed with a towel that is with soapy water, that is wet with soapy water. Okay, so we use the soap for the first. Clean the surface. Afterwards, we dry the surface with lint-free clothing. And afterwards, we begin disinfection with disinfectant solution that we have chosen previously. We make the disinfection for the first. Afterwards, we repeat again the disinfection. So we perform the disinfection once. We dispose the towel, take then the clean towel, okay, and perform again the disinfection. So we make twice. We disinfect the surface twice, okay, and the wire also with the receptor surface. After performing the disinfection, the disinfectant buildup must be removed, and we use the sterile sponge, for example, that is wetted with deionized water, and anyway, sometimes we use the ordinary water. So afterwards, after this phase, the receptor is considered that it is clean, disinfected, and we put our cleaned and disinfected receptors on the clean surface. Now on the clean surface, and remove the gloves again. Dispose them, wash our hands, put on the new gloves, and call the next patient. But you know, there is a good remark that putting and taking off your gloves is very essential to perform before the patients. It's better to perform before the patients. You see, so never put on your gloves while your patient is not seated in operatory room, because it is always you know, pleasant from the patient side to observe how the operator is managing with her gloving up or taking off her gloves. And just take in mind that always when the patient is in operatory, to glove up your hand, to wash, and afterwards take the disposable and clean gloves just before the eyes of your patient. So the trust of the patient that the environment is it's a high quality disinfection as in surrounding environment of this patient is elevated. This elicits or elevates its trust towards you. So just be sure that when you perform all the steps of that are recommended by the infections controls is very essential, and also it arises and it elevates the trust of your patient towards you. So after performing all, you dispose your already utilized gloves and washing your hands, putting the new gloves, taking and picking the disinfected, not sterilized, but disinfected receptor. You make the covering again with new isolating material and ready for performing the new X-ray imaging. So these are the very simple steps that explains your conduct in the operatory gantry to avoid the infection spread. But what about the PPE, or what about the clothing of the operator? That is also very meaningful to prevent the infection spread, and especially we are dealing with COVID-19 nowadays. So the operator, when performing the X-ray imaging, is also very close to the patient. So, and the patient wears no masks, because through masks, nothing is done in our discipline, in dentistry. Anyway, for other disciplines, for example, when the patients are examined for other diseases, when individuals are, when the doctors are performing the clinical assessment of the patients, they always wear the masks, okay? But in dentistry, no masks, unfortunately. So we use, you see, the eye wearings here. We use also the face shield. That is also very effective during performing the X-ray imaging, because when the patient is unaware of having, for example, COVID-19, in most cases, for example, the people are not aware because the lack of the symptoms. But sometimes when the symptoms exist, they are coughing, so sneezing, and the spread of infection from the patient to operator is inevitably, of course, is unavoidable. So the operator, due to the COVID infection, has to be placed on his head the shield, the face mask, and sometimes the spectacles. So all these parts that are that represent the items of the PPE are very hard to wear. Just believe me, because you are protected, of course, maximally, but not totally, but somehow you are better protected. But there's a very bad thing, the thing that sometimes the patient, you cannot see the patients, the mouth and the right teeth, it's very hard to perform. So be careful and just make a huge practice when making the X-ray radiograph to avoid yourself from the future infection to occur from the patient, and to make successive and good quality X-ray imagings. That, just believe me, it's very hard to perform with this kind of protective materials, so items, but there is no way. There we have for today the reality that we're dealing with this kind of this kind of infection, but there is no way, no other way, additional with those very famous, already well-known infections, also very hazardous and also very with very more higher, from my opinion, from my point of view, more higher outcome of lethality. So additionally, we have to wear those kind of items, and also
Additionally, the disposable gowns that I'm wearing now with long sleeves, you see, with closed collars, of course, is very actual for using for today for infection spread, preventing for prevention of the infection spread as COVID-19. So anyway, those recommendations, I hope that no other type of virus and viral infection will appear for the future. I don't know what, I cannot imagine. Even more, I don't want to imagine what the viruses and the mutations of the viruses are planning for the future to occur, that threatens the total population of the whole world. But anyway, we as a dentists are at first step and facing a great danger in a field of infections, and especially in a field of infections that are spread by viruses, the viral infections. So because there are blood spread types of infections and also the infections that are spread by air droplets, by exhaled air. And for us, this is unavoidable because we are very close to patients in that field. So this is very brief information in the field of infection control that we wanted to discuss and consider for today. So if there is any question in
Yes.
Yes, Adam, I'm hearing.
Yes, we have an exam on the 24th, correct?
Yes, 24.
I have a flight to Georgia on the 24th. Can I have it the day after?
I'm sorry, Hussein. I will.
Okay, Adam, you have the flight in Georgia or out of Georgia?
No, to Georgia. I'm going to Georgia.
You are going to Georgia. So, and you have to perform, I think, online or no, offline, I think.
Yeah. So
Yeah.
that's why I need the.
We had meeting with Dr. Natalie, and they decided the administration to have online for them.
Okay. It will be performed online.
Yeah,
Yes,
but I still can't
clinic.
do it.
Okay, if you make them online. So do you hear me? It's
Yeah, I
better
can hear you.
maybe for you to make online, I think.
Yes, but the time of the exam is at 4. No,
At 4.
it's at 12.
At 12 o'clock.
And my flight is out of Amman, Jordan. It's at 10, so I can't.
Okay, you cannot catch up with the examination. That is the problem. Yes.
No, so if I can do it like a day after.
A day after.
You will. You suppose.
Yes, a day
request
after.
this from Dr. Sofo.
Yes, of course.
Oh.
Adam, you have to ask about it, Dr. Sofo. Okay, it is better because Sofo manages with the examination office.
Yeah.
Yes, and that is a problem. Yes, I see. That is a great problem.
Do you think there's a problem with delaying it one day, or they'll accept it?
You know, 2 days before they were discussing about, there was a discussion about the making up the examinations, and there was something, some troubleshoots according to the decision of having just at the same time or just postponing the examination. So I cannot, unfortunately, exactly say definitely what will be the attitude of the examination office towards that. You see, but anyway, yes. It will try to change the schedule of having the examinations, but they are very. This period is very loaded with examinations. Yes,
Doctor?
because there are the OSCE, of course. Yes, Yosef.
When before you finished this explanation, you explained from Hubar book.
Yes. This is a very little topic from the Hubar.
We
Very
must
little
study
topic.
also from Hubar.
Yes, maybe from Hubar. Just go. This is an review, like review kind explanation of the infection control. So in not always we perform every step, but we perform every step, but sometimes we use other items that is explained, that is shown here. But anyway, you have to read Sarah.
Sorry, Professor, I can't hear you. I don't know if you've muted yourself.
Yes, she muted herself.
Doctor, you're on mute.